Go ahead, Oko.
Hello, everyone. Welcome to Communities Alliance and Networks event in partnership with WHO IPB Networks. Today, we'll be discussing sexual reproductive health, rights of Indigenous women, girls, and gender diverse communities living with HIV in Nigeria. I'm excited about all the wonderful conversation we're going to have here. My name is Ogo Iwora, and I am your host for this section. Next. So in today's agenda, we'll be having a welcome remark by Godike Nari. He's one of our chief from Indigenous community in Anambra State. And we're going to have Carrie Martin introduce a section on the research that has been conducted by CAN. And we'll have 3 other speakers that will talk to us before we open the section and have questions asked to the speakers for this event. So just to say that before we begin, let me remind you that this section is recorded and that for your future reference. So if you want to download any of the presentation, please feel free to click on the download section, download the handouts, and download all the presentation. All of them is available. For questions, click on the question area and type in your question. After the presentations, we'll be sharing those questions and reading it out to the presenters, and hope we'll have enough time to address the questions and your concerns over the presentation that will be delivered today. Please feel free to use the link provided on this page right now to visit our website to learn more about our programs. Next. So I'm excited to welcome Chief Dr. Ima Enemor. He is a representative of Indigenous communities in Nigeria. Chief Dr. Ima Enemor is known as Godike Nari. Looking at his profile, you will see that he's an elder spokesman who has laudable accomplishments in academic sector, and is also in touch with his people through his contribution to the communities. Presently, he is the chairman of Adamanri. Adamanri are the kingmakers of the ancient kingdom. So we're really honored to have you. Please join me in welcoming Chief Ima Enemor to give us the welcome remark. Thank you.
Thank you very much. Thank you. It's really an honor to me personally and to my community to have this invitation to participate in this August program. I wish to start by thanking all the organizers. I wish to thank all the moderators, all the facilitators, and in fact, all the presenters, and indeed everybody who is participating. I'm excited that this program is centered in Oka, capital of Anambra State, which is my home community. I wish on behalf of my community to welcome all of you and thank you for organizing this program. I wish to hope that this program will be able to find its way down to the target population, which is the rural communities, especially living with HIV/AIDS. And this community, this target population, obviously have very little sources of information and education in health matters. So if there's a way this program will get down to them, because I know that a good part of the target population do not have the facility to participate in this kind of program. And I hope that this program has the inbuilt strategy for getting down this information to them. I wish to once again thank all the organizers and pray to the Almighty God to guide you all through this program. I wish to say a short prayer. And this short prayer I am going to say, the traditional way of saying prayers in Igbo land is through the breaking of traditional kola nut. And that is what I am going to do. I would like to crave the indulgence of people who don't understand Igbo, because I am going to speak in Igbo. That's the only language that the kola nut understands. And I can't break the kola nut in English. So please pardon me as I pray, I break traditional kola nut as prayer for this program and for all the participants and the recipients. Eji m ọjị n'aka mmeji wee gọọ ndụ ndị niile bịalụ ịkụziri anyị etu anyị ga-esi wee na-echekwa arụ anyị. Ọjị anyị ji bụ ọfọ ndụ ka m na-eji ego, m na-ejikwa ego ọfọ mmụta ka ọ ga-abụ ife ọbụla kwa kụziri anyị ka anyị mụta ya. M na-eji ego ọfọ obi umeala ka ọ were obi umeala kụziere anyị ka anyị wee mụta, maka na ọtụtụ n'ime anyị ejechara ụdị akwụkwọ ọ ya abụfa kụziri anyị aghọta. Anyị jikwa ọjị wee na-agọ ka ife niile anyị eme na mgbakọ ọbabịa ka ọ bụrụ ife ga-abala anyị uru, ka ọ mịta mkpụrụ baalụ ndị be anyị uru, bakwa nwe uru. Anyị si ọgụ a ọjị anyị na-agọ na anyị na-agọ ka ọkpa ha ji wee bịa be anyị wee manarị ya, ọkpa ha eji wee na ya marị ọkpa ha ji wee bịa be anyị. Eji m ọjị na-ekene ba niile wee na-asị Olisa bi n'igwe na ndị mmụọ dị be anyị na obi nna nna anyị fa gọzie unu niile, gọzie anyị. Anyị atọ ọjị n'iberibe mana kwa ya ata n'otu. Anyị si ọ ya dịrị unu mma. Nnọọ. So finally, I wish to once again welcome all of you. I wish to thank all of you for this August program. And I wish to wish everybody very happy, very fruitful deliberations. The success of this program will go a very long way in improving and maintaining the health of the people of our area, and in fact, the entire world. I thank you once again. Thank you.
Chief Nemo, thank you so much for that beautiful welcome remark. And I want to say to all your prayers, it will be well with all of us. Apologies if you cannot hear you, but that was a wonderful prayer, praying for success of this event and praying for all the people that have been involved in bringing this particular initiative to Anambra State. Chief Nemo, we're very happy to have you on board, and thank you for welcoming all of us. So we'll be moving quickly to the presentation. Today we have 4 presenters that will be speaking to us. Starting today's presentation is Carrie Martin. Carrie Martin has been working with Indigenous women from Canada, and she'll be speaking to us on, she'll be introducing the CAN research initiative to us. Welcome, Carrie Martin, to start the presentation for today.
Hi, thank you for the introduction, and thank you so much for the opening words and the welcome and the prayer. That was, really well received and really appreciated. Thank you. So my name is Carrie Martin, and I am the Indigenous Women's Research Coordinator with Communities, Alliances and Networks, which was formerly known as the Canadian Aboriginal AIDS Network. And I am a mom of a 3-year-old boy who keeps me very busy, and I'm a PhD student as well. I am the nominated principal investigator on this SRHR grant, so the Sexual and Reproductive Health and Rights Grant. And the formal title of our project is very long. It's the International Indigenous-Led Mobilization of the United Nations Support Group on Indigenous Issues and the World Health Organization Consolidated Guidelines on Sexual and Reproductive Health Rights, SRHR, of Indigenous women and girls, leading an intersectoral response through self-determination. Next slide, please. So we've tried to shorten this a little bit. We've created a lay title that's a little easier for everybody to remember. So it is the Measuring Sexual and Reproductive Health and Rights, Responding to the Needs excuse me, of Indigenous Women and Girls in a Global Context. And when we say Indigenous women and girls, we are including anyone who self-identifies as a woman or girl, inclusive of cis women, trans women, two-spirit, feminine identifying, genderqueer, and non-binary. So it's just an umbrella term that we've used in the grant to say women and girls, but it is very inclusive. Next slide, please. So when we were designing this project, it was really important for us that the locally specific ceremonies and traditional activities were honored and that they were done in a good way. And we wanted to do this in order to ensure the safety and the health of all the relationships and all the participants in this project. And for that reason, we have engaged with elders in every country. And I will speak to that a little bit more in a few minutes, but I also wanted to speak to the fact that this project is really aimed at allowing Indigenous women and girls to get the knowledge that they need to make the best decisions for themselves, as judged by them. So there is a typo in this slide. It should be as judged by them for their bodies. So they need to be the people who are making their own decisions for themselves. But we're helping to equip them with the knowledge that they might need to make those good decisions. And the project will also enhance the ability of Indigenous women and girls to engage in research at every level. And we're going to be doing this through strengthening our global and Indigenous allied partnerships. So this project actually was made possible because of our existing international partnerships that Trevor Stratton developed through the International Indigenous Working Group on HIV and AIDS, or also known as IGWA. So Trevor had been working with a lot of our Indigenous international partners for a number of years, and because of this, he was able to bring us all together, and we were able to create this project together across the globe. Next slide, please. So the research questions that we're going to be asking are: what are the underlying cultural and structural issues women and girls face in accessing safe and effective SRHR? What are some of the cultural and structural opportunities that could increase their capacity to access safe and effective SRHR? And what are appropriate culturally responsive solutions to advancing Indigenous women and girls SRHR? And this is also where our elders are going to play a really key role here, is making sure that we are respectful of the different cultural responses and the cultural and traditional ways of doing things. And finally, how do we build Indigenous men's capacity to advocate for optimizing SRHR of Indigenous women and girls? So while we were designing this project, we knew that women and girls SRHR cannot be addressed in silos, and that it was really important that we bring in Indigenous men and boys as well to help support this work. Next slide, please. The project's overall goals will be to develop materials that are relevant at global and local levels. And this means that the different materials that we produce will not be the same across the country. So everybody will develop their own tools based on their specific context and their specific needs within their countries and regions. Our overall goal is to develop an Indigenous framework that promotes and improves well-being through the following aims. So we're going to investigate how to address underlying barriers to adequate data progress in SRHR. We'll incubate cultural informed solutions through the development of template materials with solid global partnerships. We will mentor and train Indigenous women and girls with allied supporters in global SRHR metrics and in research practices as well. And we're going to support capacity building among Indigenous self-identified men and boys. And again, there's a little typo there. It should say inclusive of non-binary people, not men. And they will be advocates and change agents for Indigenous women's SRHR. Next slide, please. So the deliverables will be developing a scoping review on SRHR. This will be specific to the global population of Indigenous women living with HIV. And this this scoping review is going to inform our focus group discussions. It's going to help us determine what it is that we need to be addressing in the focus groups in the 7 countries. There will be some common questions across the 7 countries, but there will also be very country-specific questions to make it more relevant. And the discussions from the focus groups will then inform the development of a survey. Again, the survey will be administered in all 7 countries with common questions as well as country-specific questions. And this survey is going to be administered by Indigenous women living with HIV or allied Indigenous women who have been impacted by HIV. So it's important that we have peer involvement at all levels. And finally, an Indigenous appropriate toolkit on SRHR and its care for Indigenous women and girls will be created. So these toolkits may look very different across the countries. So we just want to make sure that it's relevant in the context that it's being developed. And we will conclude with a process evaluation of the entire project. That's it. Next slide, please. So without further ado, I would like to introduce Manjula, who works for World Health Organization. Thanks, Manjula.
Thanks so much, Carrie, and thank you again, everyone. Good afternoon, colleagues, and I'm really pleased, as Carrie mentioned, this partnership that we have with the Canadian Communities Alliance Network that's, managing this great research project across so many countries, and, partnership with WHO and IBP as well to host these webinars with the partners in Nigeria, and it's really great to see that this webinar has been made possible. So the purpose of this presentation is really to provide a brief overview of the key principles behind the development and an overview of the guideline itself. This is a consolidated guideline on sexual and reproductive health and rights of women living with HIV, which was published in 2017. And it's really the outcome of a broad consultative process that involved, national, regional, global experts that included healthcare providers as well as policymakers, program managers, particularly at country level, and UN agencies, ministries of health, national AIDS control programs, and particularly many networks of individuals and networks of people living with HIV, and that included representation from Indigenous women living with HIV. So the rationale and the scope of this guideline is really because many countries, women living with HIV do not have equitable access to good quality health services. And they are also faced with multiple intersecting forms of stigma and discrimination. And we hear about these stories over and over across most of the regions that we have encountered, and the women living with HIV, particularly from resource poor settings, are disproportionately vulnerable to violence and violations of their sexual and reproductive rights. So this guideline starts from the point when women already know that they're living with HIV, and acknowledges that for those who are not aware of their status, they must first be reached by safe, voluntary, non-coercive HIV testing and counseling. So although this guideline focuses on women living with HIV, we do also acknowledge that sexual and reproductive health and rights for many women in resource poor settings could be similar. But we are focusing here on the particular vulnerabilities that Indigenous women face with regards to being able to not only access quality healthcare, but being able to have a safe, supportive space in which their sexual and reproductive health and rights are acknowledged. Next slide, please. So this is just quickly to say that among the many leading roles of WHO is the mandate to develop high quality, evidence-based guidelines to support countries and communities. Next slide, please. And very briefly, what we mean by a WHO guideline is is outlined. We do follow a process that's quite standardized, that's described in this handbook. And what we mean by recommendations are information that can be useful for policymakers, health workers, and also the end user, and in this case, women living with HIV. And it implies really a choice between different interventions. It's based on evidence, and it has ramifications for the use where there's limited resources. So there is issues related to cost and equity that come into play in each of the development of these recommendations. Next slide, please. And this guideline adopted a perspective that was, I wouldn't say unique, but that really grounded in the perspectives of women, their families, and communities. It adopted an approach that didn't start from what the expert needed to say, but what the women and the girls, including Indigenous women and girls living with HIV, had to say about their own sexual and reproductive health and rights. Next slide, please. And so some of the guiding principles are included on this slide. And first and foremost, like I said, it adopted an approach that is centered around the needs and rights of the end user of this guideline, which are women, girls, gender diverse individuals living with HIV. It really sees them as active participants, as well as beneficiaries of trusted health systems that respond to their needs, their rights, their preferences in holistic ways. It emphasizes the promotion of gender equality as central to the achievement of their sexual and reproductive health and rights. It in many ways requires that women are empowered with education, with support, to make and enact decisions in all aspects of their lives, and including in relation to sexuality and reproduction and HIV. So the guideline itself is organized around their health needs and priorities. And I'll get to this a little bit more in a minute. Next slide, please. So one of the key principles was about meaningful community engagement. So what was unique in the development of this guideline was a global survey which was conducted by and for women living with HIV to assess their priorities. And this was called a values and preferences. So it was a global survey, and some of the key aspects of this report, and this is the cover of the report, and the link is included here. So some of the key aspects was about the extent of the violence, stigma, coercion, discrimination that was systematically faced by women living with HIV, and the resulting mental health concerns. The report also highlighted the need for quality, respectful care within health facilities and in the hands of health workers, which was felt to be really lacking, in particular for those who are made most vulnerable due to their circumstances and who are marginalized or criminalized or stigmatized in any way. Next slide, please. And so this is the framework for the guideline. And you can see the same image of the house that came out of the Values and Preferences Global Survey is at the center of this guideline. We place the needs and the rights of the women at the center. And in addition, you can see in blue the health interventions around various areas of sexual and reproductive health and rights. And in purple, the elements of an enabling environment that would be needed in order to implement the recommendations. Next slide, please. The sexual and reproductive health topics which are covered in the guideline align with the WHO Global Reproductive Health Strategy. So it includes some of these areas. I'm not going to read them out, but covers areas related to maternal health, family planning, sexual health, and STI, cervical cancer, and issues that are cross-cutting, such as gender-based violence. Next slide, please. And as I mentioned, the enabling environment also becomes really critical here, and we know that there are many challenges which we've highlighted, but the guideline attempts to provide strategies in order to improve and be able to create that enabling environment in order to implement the guidelines and advance the sexual and reproductive health of women. And that includes improving accessibility to quality services, acceptability of women themselves with relation to the recommendations and the services that are available, the affordability, the equitable coverage of these interventions. Next slide, please. And so the guideline includes recommendations, both for that enabling environment, which I just mentioned, but also specific health interventions around SRHR, which we just mentioned. And you'll notice that in the guideline, each of the recommendations, each of these sections include that little house that I noted before in the framework, because the voices of the women and their priorities were included in the development and in the wording of the entire guideline. Next slide, please. So there were recommendations, but there were also good practice statements, again, for the enabling environment, such as psychosocial support, such as the need for healthy sexuality across their life course, such as the need for protection from violence and social inclusion and acceptance, and also various health interventions, as we've already mentioned. Next slide, please. So the guideline was published in 2017, and this unique process of community engagement led to it being accepted as one of the gold standards in guidelines from WHO, and the establishment of a WHO advisory group of women living with HIV. It's the only community advisory group of WHO, and it includes representation of Indigenous women living with HIV. Next slide, please. And while we recognize that there are many excellent initiatives and programs and policies that already exist in countries, implementing these global recommendations and good practice statements really needs for it to be adapted to the local context. And in our experience in implementing this guideline, the communities which need far better care are Indigenous women living with HIV, are communities that include transgender persons, migrants, incarcerated people. And again, we hear about these stories and these challenges across many countries and many regions. And so having the guideline alone is a good start, but is not sufficient. And the implementation and the uptake of these recommendations at country level requires the partnerships and the support that the webinars such as these provide. Next slide, please. I just wanted to share these words from Marama from New Zealand. You know, it has really been an honor to work with so many individuals and communities living with of women living with HIV in the development of this guideline. And we really continue to look to you and our partners on the ground to help us adapt and build the guideline better. The guideline now has a living format, which is a web-based format, in which we will continue to update and keep it relevant. And as new evidence comes, including through this research project, we will continue to update the guideline so that it will continue to evolve. Next slide, please. The next slide has, so this slide has the resources, which we hope that you will feel free to use and make available. It includes community-led strategies for the implementation of the guideline and case studies that was developed by and for women living with HIV. So please feel free to use these links or reach out to me for any further information. Next slide, please. So this is just my last slide, and I really wanted to thank everyone again, and really an integrated approach to health, to human rights, to gender equality lies at the heart of ensuring the dignity and the well-being of women living with HIV. I really look forward to receiving feedback on how best we can implement this guideline in Nigeria and in your region, and so that we collectively we can overcome the barriers to service uptake, use, and the continued engagement that we will need so that we can reduce stigma, violence, and all of the challenges that women and girls living with HIV face, and ensure that we can advance their sexual and reproductive health and rights. Thank you all very much. I think the next speaker is Dorcas. Over to you.
Good afternoon, everyone. Please, next slide. So I'll be walking us through the challenges and opportunities of the things we've discussed this afternoon. Next slide, please. And I'll literally be talking about what we've been able to do where I work in Delta State. And of course, we'll look at those key challenges and opportunities contextualized to our settings. And if we have time, we'll take further discussions at the end of please. I think we're 2 slides behind. One more slide, step back, please. The challenge now is not having data for Indigenous women living with HIV. And I did check, is an indication that the world needs to look closer at this cohort of people across all the strata of society. Next slide, please. Now, in reaching out to go and get people on board for the ART surge response, the mandate was simple. We just needed to reach the unreached, and that unreached met the vulnerable populations with limited access to reliable treatment. Next slide, please. And we've not done too badly for Delta State with 69,000 people on treatment and a suppression rate of 95%. We are on track for epidemic control. Next slide, please. Our scorecard for women, we have just close to 6,000 women collecting care and treatment at the 5 KP OSSs that we have in the state. Now, the OSSs being one-stop shops that serve female sex workers, men who have sex with men, transgender populations, and people who inject drugs. And what we've been able to do with the over 30,000 women aged 15 to 45 who are accessing HIV care and treatment in Delta State is that we've been able to provide wraparound services for them. We've been able to provide cervical care and cervical cancer care and treatment. We've been able to provide conception care and PrEP for patients who are members of serodiscordant couples. We've also been able to provide GP-free support. So we're already reaching these people for HIV care and treatment, and it's just being able to layer in other factors, other services to these people that we're already reaching. Next slide, please. Now, the challenges to women accessing sexual and reproductive health rights at the indigenous levels for women living with HIV are cascaded into those that stop the woman from taking up treatment and those that also stop her community from being interested in having those services. But first and foremost, they need to know that these services exist. Are they safe? Are they accessible? Are they close enough that they can be accessed in an emergency? And are they acceptable to the society in which this woman living with HIV lives? Next slide, please. Now, we started this webinar with a discussion from Chief talking about us taking this information down to the grassroots. And usually the most common way we would do this is to use mass media, so radios, TV spots, newspapers. However, when educational status and low economic status is compounded by geography, then what it means is that the target population that we need to reach with these messages are being left behind. Next slide, please. And I know some people will say, oh, the current trend in the lower age bands is that people are using social media or they're going on the internet. However, in that population of people accessed in the rural communities, less than 60% own a mobile phone of any kind. I'm not talking about an Android phone, I'm talking about any phone. And less than 16% had used the internet for anything in the past 12 months. And this is based on the DHS 2018 data for Nigeria. Now, what this translates to is that when you have people that don't even know about their sexual rights, they don't even know about the services that are available, then it now becomes more of a challenge because they cannot talk about self-determination or use of reproductive services if they don't even know that they exist. Next slide, please. However, it's not all doom and gloom. We do have opportunities, and the indigenous communities, what people might see them disadvantaged, they do have the benefit that the opinion leaders in those communities still wield a lot of respect, a lot of control, a lot of information, and they're able to mobilize their people to access services if they're provided in a culturally acceptable way. We also have communities that undergo seasonal migration. They go from one place to another during the calendar year. We've leveraged on this as an opportunity because if you know that they're going to be upland for 6 months, you can give them multi-month dispensing, and when they come for their next appointment, you can wrap around them the services that they need to uptake at that time. Next slide, please. So this is just a snapshot of some of our testers going into the creeks and shores off of Warri Coast. Some people are on the waters for 2 hours just to take services across there. And what would help in trying to make sure that we're able to implement these guidelines at the local level is to make sure that you leverage on these kind of things that are already in place. So if you're already reaching these women for one service or the other, then it only makes sense to be able to do this for other things as well. It's not easy, it's capital intensive, but if it was easy, then everybody would do it. Next slide, please. So I've tried to label this, walk through this in terms of the guidelines that we already have. Now, of course, stigma and discrimination has been with us, and we have that fear of being outed as members of the LGBT community in Nigeria as well because of some of the punitive laws that are in place. But if we use the opinion leaders and traditional rulers that we are engaging for entry into the community to also spread the messaging of you equals you, that message of faith and hope and love, that ART treatment works, and women and men who are adherent on their treatment and achieve viral suppression are unable to transmit it to their sexual partners, then we are able to leverage on the opportunities brought by the expanded ART coverage that Nigeria is currently engaged in. Next slide, please. Now, COVID in the past 2 years has dealt many people a harsh blow. It has not been easy in terms of economics. But I was also pleased to hear earlier on about speaking about involving women living with HIV in their care and letting them be the self-determinant forces behind their care. And this helps. Discriminatory laws and policies in place. We have an absence of some laws in some places that affect the rights of women generally in Nigeria, and then of course those that have them that do not support gender equity or gender parity. But what we can continue to do is continue to engage policymakers and of course the provide healthcare services within the confines of the legal protections of Nigeria. Now, the passing of the Delta State Anti-Stigma Bill in the last few weeks is showing light at the end of the tunnel, that we are able to meet up with this and continue to push that conversation. Next slide, please. We are 2 slides behind. Also, for the integration of sexual and reproductive health and HIV services, we're able to leverage on universal health coverage and make sure that when people are accessed, because most of the HIV services are free, but the wraparound services may or may not. So if we link these women to the national health insurance schemes, to universal health coverage, and they're able to also access and benefit from those services. Now, we do have situations, and you would expect that having more than one partner in an area would lead to synergy and cooperation, but there is that territory marking among some people, so we need to continue those conversations and make sure that we can leverage on the services that other people are providing. Now, we have traditional birth attendants and faith-based healing homes in almost every community in Nigeria. And what we've been able to do on the 4 Gates project that's been implemented by Caritas Nigeria is to make sure that we train these people, we provide them with test kits, we engage them for screening for STIs, as well as for cervical cancer and other opportunistic infections. It works because they're trusted members of the community. Next slide, please. And there are also key people that we can use to drive the conversations around sexuality, contraception, and prevention of perinatal transmission of HIV. The women leaders also active in the community are also key members of these communities, and they're also able to drive this conversation in safe spaces, because the cultural norms and traditions in Nigeria do not always support the open discussion of sexual and reproductive activities in Nigeria, among the younger age group and among women as well. And then we have overseas services, orphans and vulnerable care services that are available, also working in the communities at the grassroots. And what this helps us to do is, if we can leverage on that, then we have more people looking out for children and young females who are also at risk of having challenges with their sexual and reproductive health, especially those already living with HIV. So in conclusion, it's going to take deliberate and strategic engagement of the community gatekeepers to make sure that women living with HIV at the indigenous level, at the local level, in the communities, are provided with the care and services that they need the most. This includes the key population, because without engaging their community leads, we would not have been able to have as much as 6,000 women on treatment across the state. And also they will need extra support to live their best lives in terms of sexuality and reproductive health. Next slide, please. As always, I'm always available to continue this discussion. This is where you can reach me. Next slide, please. Thank you for listening. Next slide, please. I'll be introducing Dr. Walter, who will be taking the next session. He works with CISHAN, and he has extensive experience in the country providing indigenous and vulnerable people with support in terms of living with HIV. Dr. Walter, over to you.
Hi, everyone. Good afternoon and good morning to our colleagues in Canada and other parts of the world, and you're most welcome. So first, my work is made easy a little bit because I'm asked to discuss the part that has to do with the how question, and in terms of how to operationalize the guidelines for SRH issues in the country from WHO perspective now to our country context and how we can really look at it. Please go ahead to the next slide. So I would first of all want to start with this very important and basic reminder for everyone here that actually HIV is not only driven by gender inequality, it is also entrenches gender inequality, leaving women more vulnerable to its impact. Providing sexual and reproductive health interventions for women actually is the grounded principle for gender equality and human rights, and can have a very positive impact on the quality of their lives. It also has a step forward towards a long-term improved health status and equity in the overall. So I will first of all try to look at some of the things that we can do from the national to the state and down to the community. I'm a member of the Indigenous group. I work for the Civil Society for HIV and AIDS in Nigeria. And to be honest to all of us, please go to the next slide. To be honest to all of us, that Nigeria have made a tremendous progress in terms of reaching 95, 95, 95. But this tremendous progress has come with a very huge impact and a very huge gap. And that huge gap is coming out that there are a lot of rights violations that we cannot begin to mention. And we are beginning to see that the stigma and discrimination that has come along with meeting this treatment target is huge. And such that we will need to find a way to start thinking out of the box and seeing how we can really garner support. And this guideline by WHO is one of those tools that we really can use as community to gather ourselves and come together and see how we can operationalize it and make it really relevant to our local context. So I've kind of read through the guidelines, read through strategies and what other countries have done, and try to put forward what we can do in terms of just step by step. In terms of creating an enabling environment, we actually will need to wear our shoes back again as civil society and as indigenous communities to step up with advocacies at all levels to shout out and voice out some of these SRHR issues that and violations that have happened and issues that are being sidelined while the treatment gap was being closed. And by that doing, I've tried to look at to say that one of the things that we really need to go back to doing is to say that we really need to catch them young in secondary schools and in tertiary institutions by re-establishing the SRHR clubs. I know in many years ago, 15 years ago, when I used to be very new to the HIV response in Nigeria, we used to have this, but we need to go back to all of that. And just like my colleague alluded to the fact that we have a huge gap in Nigeria where we are battling with our PMTCT figures. We're battling with our PMTCT figures just because we have refused deliberately as a national response to recognize TBAs as part of our care system for responding to HIV and AIDS. And we all will stop at the primary health care level. I will not go to the TBAs. And for every program that have recognized TBAs, have seen a differential shift in their HIV response. And for us, it is time that we will say it, that it is time for us to recognize traditional birth attendants and decentralize SRH services to the TBA home so that they can help us to do testing, they can help us to provide FP services that we can train them to provide, and also help us to close the gap in that. And of course, again, we have also left the peers. Majority of the adolescent services we provide these days are provided by women who majority of the adolescents are not comfortable with them providing the services to. And that's why, because we have mentioned the fact that discussing reproductive health issues by adolescents in the communities are sort of a taboo. But actually, the adolescents are discussing it at our back without having us, just because we are not including the peers in the program's design and in the program implementation. That's why we are falling back and having challenge with reaching them. So in operationalizing this guideline, we really have to find a way to bring on the adolescent peers and make sure that the AYP is captured actively well in the program design that we are designing. Next slide, please. Yes, also in terms of protection from violence and creating a safety, we have not made any progress with our Anti-Stigma and Discrimination Act or Anti-Stigma Act. Why? Because we have not established a tribunal for the Anti-Stigma Act. And majority of the times, my office deals with helping to acting as a liaison for people who would want to challenge institutions, want to challenge individuals who have stigmatized them. And each time we appear in court, one of the critical questions they keep asking us: this court is not suitable to hear this matter. This court is not within the jurisdiction of this court. And they keep referring to the fact that when the Anti-Stigma Act was enacted, there's supposed to have been a corresponding tribunal that will help us, just like we have in Kenya, that will help to deal with matters about discrimination and all of that at all levels. And in fact, and also, just like we have seen in Lagos, we now need to move towards integrating SRHR issues in GBV existing tribunals and courts. And the GBV guys were very quick in getting the GBV Act done and also getting a tribunal to do that. But one opportunity we can have is to see a way of integrating SRHR violations and also HIV-related violations into the GBV court that exists. But I'm sure that it's only in Lagos that we have got the GBV courts and tribunals. We don't have them majority of the states, so we might also need to do some step down. And of course, we know that Thank you, Ogonari, for the wonderful welcome remarks. For all programs on HIV and SRHR issues that have worked in communities, especially in Igbo land, the men play central role in making sure that we remove cultural barriers around issues within the indigenous communities. And this is how we can also operationalize it, using men, using the traditional institutions, the Eze in council that we have. When I used to be the lead for the HIV intervention in Anambra many years ago, we know that we make so much progress in stigmatization and discrimination of people living with HIV and AIDS by just using traditional institutions that we have. And I do think that we still need to use this. And of course, we need to be expanded a little bit in terms of mobilizing and networking with the Federation of International Lawyers and all other women lawyers, international women lawyers that we have in Oka and every other parts of Nigeria. Why? Because they help to provide free legal aid services to those who would want to challenge, who want to go to court and challenge their rights as being violated. Please, can you go to the next slide? So in terms of the health intervention, so I hear a lot of things, but I've led civil society organizations to do a lot of community-led monitoring in Nigeria. Our family planning and our HIV services are not co-located at the moment, and they are running separately. And my colleague tried to use the word marking of territory. The territorial marking is very real, and because of this issue, because of this territorial marking, just using our words, they've kind of gone a long way to making sure that HIV services and FP services are never located. In fact, even at the federal level, the HIV services and the family planning services are not located, are not doing the same thing, are not speaking to each other. And we would want to see, if we are to operationalize the guideline, we want to see the HIV and FP, which on the overall rights, the SRHR services to actually speak to each other and most possibly co-locate themselves. And of course, if one of the things that have worked within COVID, which we did, was that to use HIV self-testing as a mechanism for partner notification. All the partner notification violence that has erupted has had to deal with, us making an unnecessary and unwarranted disclosure about the partner's zero status. So if we use HIV self-testing, we think that we'll be able to operationalize this guideline in terms of the health interventions that have been doing. And of course, again, we will now need to find a way to include HIV family planning services in the PMTC treatment casket. At the moment, it is not there. What is there is just giving lubricants and giving condoms. And for us, that is not a proper SRH. And I like the way that the diagram that was shown by the colleague from WHO. You can see that we have a whole lot of services that are being missing there. We need to bring them back. And of course, connecting our PrEP access to family planning services, I keep saying it, treating STIs in the same clinic with FP clinics. HIV one-stop shops have tried to do this in providing family planning services. But if you go to the family planning clinic, there's nothing about HIV being provided in those services. And a number of our services are being provided with donor resources. And unfortunately, they are not in focus with family planning. Those in focus with family planning are not in focus with HIV. And that's why I said the line gets thinner and thinner along the curve. And of course, we also need to break the barrier about ANC for PHCs and hospitals alone, and bring in the TBAs and connect the HIV and SRH treatment services to the gender-based violence services. And I keep saying it that one of the critical things we are having in the recent time as we are marching up to 95 is the fact that a lot of GBV issues are beginning to emanate, and this tool or this guideline will help us to form the basis for addressing and starting to talk about them and to shout about them in the community and everywhere we are. Next slide, please. Yeah, so before I end, what else exactly are we not actually thinking? And for us, I try to say that what can help us is that we have a huge opportunity in Igbo land called the August meeting. And this August meeting, virtually, going everywhere now. And this August meeting is an opportunity for the women to discuss some of these issues and agenda that they usually have within the indigenous community. And this is Indigenous, and everyone that witnessed what goes on in the August meeting will know that it is very, very important and a tool that we can actually use to turn things around. And of course, I hear the data our colleagues said about social media, but I tell you the truth that whatever thing that goes on Twitter, goes on Facebook, goes on every other Instagram page actually cascade to the community, because when we try to find out the information used by majority of people on social media, you see that whatever thing they read, they immediately, the people who are in the city call their ones who are going to the villages and inform them that this is where we are going to vote, and we are going to do this, we are going to do that. So that information passes on its own, on itself. One of the things again that is coming up is the conversation on user fees, and we cannot implement these guidelines, or we cannot operationalize these guidelines without having a conversation on user fees. I do not know for reason why we have come to introduce user fees in terms of asking women to pay for services in the treatment facilities that are absolutely free. I have not been able to wrap my head around that, but if we need to operationalize this guideline, we must be able to eliminate user fees and say bye-bye to user fees, especially for Indigenous women. And all of us, we also need to have a conversation around the budget for SRHR services, because the budget for what we have seen is highly inadequate, and we cannot continue to keep it that way if we need to operationalize it. And we need to make a deliberate effort to scale up services, and we now need to focus on Indigenous women in terms of padding up the services for adolescent girls. I said to it, and a lot of conversation happens, and majority of the rape victims, or majority of the violations that happen in the communities are actually because the adolescent girls are not being involved, are not being centered. There might be deliberate attempts to reach out to women, but adolescent girls are still being left behind and are still being dumped there, and we always make assumptions for them, which actually should not be. And in terms of interpreting the big data, and this is what has always people ask and confront with us at the national level. You have data, you have international data, you have local data, but how exactly do we interpret this whole big data we have to the likes of Ugo Nambi? Maybe he's well educated, he may understand, but there are also millions of traditional rulers, or thousands of traditional rulers, who have no idea how this big data add up to their community and how it concerns them. So oftentimes when we speak to them and we quote national data and international data, they see to us and say, okay, that's national. But we must be able to find effective way of communicating and passing the information on this big data we have to the community heads and the traditional heads, using local languages that are very, very culturally appropriate and specific to the situation on ground. This helps us to make progress. I remember when we were having a conversation on the National AIDS Indicator Survey, and we were trying to interpret HIV in Igbo language, and it was very difficult for us. What we arrived was HIV. Each time we do this, and this was stigmatizing on its own and could not help us to make any progress. And if we, go in that direction, it will still be revolving around the challenge. We will not be able to solve it, and will not be able to operationalize the guideline. Please go to the next slide. So I'm now taking this opportunity to call for action. I'm sorry, I'm from the civil society, and I always do call to action every time I'm given an opportunity to call. So I'm asking the federal and the state government to actually find a way to deliver a program and adequately resource SRHR issues and HIV-related issues. Take ownership. At the moment, our program is still being funded by international donors. Take ownership. I'm also asking the National Assembly and the state assemblies to step forward and create a tribunal that will be able to be responsible for issues of violations of SRHR and also the anti-stigma act that is already existing. I'm also asking the National Agency for the Control of AIDS and the Ministry of Health, the family planning and HIV services, they are running like a bicycle, riding in different directions. It is time to harmonize your effort and put words into action, rather than all just sitting down there and keep asking us that we should go and do it in the community. I'm also asking the international funding organizations. I'm happy that this research is coming up. It will bring up a lot of those gaps that will do exist and help us to do this. My media colleagues who have personally invited to be part of this event, I'm kindly asking all of us that we should share the information, post this information and disseminate this information to our communities and our fellow civil society organizations. It is never time. We're not going to be tired. We'll keep talking about it. We'll keep shouting it, and we'll keep taking advocacy to everywhere it needs to be until we are sure that not just the guideline is operationalized, that will have an end to HIV and AIDS come 2030, I will propose. Thank you very much. I think that should be my next slide. Thank you very much. Let's change the story. Let's change the narrative and let all of us have an improved lives for both just women, not just the women, but also for the adolescent girls. Thank you so much.
Thank you so much, Carrie, Majula, Dorcas, Dr. Dorcas, and Walter. It's been quite interesting listening to you talk so passionately about what we're going to be seeing with regards to the research that will be coming up, and with research that will be coming up, and also looking at what the WHO guidelines are. Dr. Dorcas, we couldn't hear most of the time you talked, but it was quite interesting learning about the challenges and the opportunities that exist for us in implementing sexual reproductive health research in Nigeria. So what we have now is a section to for the audience to come in and ask questions. So I will first try and read out some of the questions we have here. I don't know, once I'm done, I'll give opportunity for people to ask questions that are already not given here. Someone said, I think that's Amadou, forgive me if I didn't call that name correctly, Amadou S. Jallo. Okay, he has left, but he had initially wanted to know, ideas regarding how he can access the webinar. I think that information was provided in the chat section. There were other questions to Carrie Martin. Carrie, there was a question on who are non-binary people. Did you see that question?
No, I didn't see the question. So we're just talking about we're talking about people who don't identify as cis. So people that like two-spirit, people who don't just fall into like the male, female norm of cisgendered.
Okay, so thank you so much, Carrie. And just before I let you go, Carrie, it was quite interesting hearing all the plan that has been put in place to enable you to conduct this research. What is not asked here, but I am interested to know, and I don't know if you can respond to that, if there are plans to disseminate the findings from this research, and when we're looking to do that, and who we're going to be involved in that dissemination, because a lot of people are gleed and want to just learn about the findings from this research.
Yeah, so we haven't started collecting any data yet, and this is a 5-year project. So we're having our first in-person meeting, our first global team meeting will be this June, and we're hoping to start really hashing out what the research questions are, and then maybe start collecting research over the summer or this fall, because we still have to go through research ethics. Findings will be distributed as we go along. This will probably be done through conference presentations, publications, and I think that it seems logical to also have webinars so we can reach broader audiences. But how we disseminate the findings is really going to be a team decision. So each country will have a community advisory council, and they will really be guiding the structure of the project and how we'll disseminate findings and when and to whom and things like that. But I would imagine that the first release of data would be to the Indigenous community first, and because we want this data to really be by and for Indigenous people. So presenting to Indigenous communities would make sense. However, we haven't gotten to that point yet where we're going to decide who and when and how, but we'll keep everybody posted. There will be a page on the CAN, on the Communities, Alliances and Networks website, that will have key project information, and we can provide updates there as well about any dissemination of findings.
Okay, so thank you so much, Carrie. I'm just going to read out another question from, this will be Oluyemisi Ayola, and the question is, Nigeria is making good efforts in HIV care. Would you perhaps say the rural communities, particularly women, are being left behind? She didn't ask this question particularly to anyone, but I'm thinking Walter Ugwucha can answer to this. Hello.
Who is the question for?
The question was not directed to anyone, but I was
Okay.
asking if Walter would want to respond to this.
Yes, I would say that we're making good progress, very good progress, except the fact that our PMTCT is not where we need it to be. So our women have been left behind in that regard. That's one. Most importantly, our SRHR services are not adding up with for the indigenous community. It's not adding up. So in that inside, they're also being left behind. Thirdly, we are not involving the adolescent girls we need to do. Remember, Malama said, nothing for us without us. So we really cannot make good progress without the indigenous community, the adolescent girls, being on board in the HIV program we're doing. Then finally, we are also not able to actually do we have something we call one-stop shop. But this one-stop shop is for the community, for the indigenous, for the KP and all of that. For the indigenous community, we do not have something like that. If you ask them to go to NHIS for the health service, who pays for it? You're going to have huge service fees on the indigenous community. So we're leaving them, we are failing them in this regard as well. Thank you.
Okay, thank you so much, Walter. There are add-on questions from Oluyemisi, and he wanted to know who you mean when you refer to indigenous women. The question says, are they rural women or women of particular tribes? So Walter, over to you again.
Yeah, so first is, my colleagues from Ken might be able to answer that question more from, but for indigenous communities are women from rural communities. Remember now, communities could be physical location. It could also be community by virtue of either gender identity or by relations. For instance, you have community of people living with HIV and AIDS. This is a community. You also have the Nri community in Oka. This is also community. So that in terms of defining indigenous people, this is what we mean by them, by the indigenous people, who are aboriginals, so to say. That's what Ken was before now. Who are aboriginals and who naturally identify and are from that community naturally. This is what we mean by indigenous people.
Thank you so much, Walter. Just before we go over to the next question, Dorcas, Dr. Dorcas wanted to make additional comments. We know we lost her quite a while during the presentation. I think that's due to network. You have the floor, Dr. Dorcas. Go ahead. We're losing you.
Hello, please confirm you can hear me now.
Yes, go ahead, please.
All right, perfect. So just to say that some of the things that we're looking out for, if we leverage on structures already on ground, we will reach more women faster. The indigenous community varies. In Nigeria, you're called an indigene if your grandfather or your father is from that place where you are, but then you still have indigenous, like my colleague, like Walter was explaining earlier, in terms of the community or the geography or the socioeconomic status or educational status that you find yourself in. Now, for adolescent girls, we are actually trying to make sure that we're reaching out to them. Peer-to-peer support is critically important. We need to drive those discussions. We need to drive that communication. For the HIV program, and I think most implementing partners are carrying this out. I'm very sure that CDC implementing partners are doing so. We have what we call the Operation 000. So that's 0 new infections, 0 missed appointments, and 0 viral loads. And what we found is that with the transitions to DTG, viral suppression is going up. So they're living well, they're looking well. We're supporting them with income generating activities. They're blooming with their education, and they're becoming spokespersons for their communities. So I think while we do have an uphill challenge, we must not forget that we are making progress every day. And we are going into the creeks, and we are going into the hinterlands, into the hard to reach communities. You have people going as far as 2 hours on a motorcycle, roads that cars can't pass. So I think, like we've said earlier in this webinar, the conversations and the synergy between the different organizations needs to be strengthened. But I do think there are a lot of opportunities we can leverage on. And I'm really pleased that this discussion has started. Thank you.
Thank you so much, Dr. Dorcas. It was quite interesting listening to the conversation or listening to your presentation. One of the things that struck out, and I don't know if you could speak on it, it's you recorded when you shared the scorecard for Delta State, it was looking really good. And I'm sure that most of us will be interested to just learn about the best practices that you could recommend in getting the support of government and partners to back up whatever initiative that is being put out there. Water has talked extensively about having them, lead on this. What can you share with us as best practices in getting them to be involved and getting their support through your implementation?
Okay, so I'm going to fangirl a little. The executive governor of Delta State, Dr. Arthur Ifeanyi Okowa, I'm a huge fan. So we've got that problem with politicians. Of course, they'll say Nigerians fantastically corrupt and this and that. But I don't know if it's because he's a doctor. I don't know if it's just his mindset. He's one of the politicians in Nigeria that I'm a huge fan of. So when we had the ALT surge launch in 2020, he came on board and he made some landmark pronouncements, including the commitment of 100 million naira towards the HIV fight in Nigeria. And what he's done is that every member of his team, of his cabinet, has been actively involved. We've had instances where we have the minister, the commissioner of information come and did discussions at trainings, the SACA, the SASCA, the Ministry of Health, they're all on board. And where we couldn't buy test kits, the state provided. We have senior members of the Ministry of Health going out with us into the communities for testing. And that ownership is there. The state knows that, look, these people are Deltans, first and foremost. So partners come, partners go, IPs come, IPs go, donors come, donors come. These are our people. And they're actually driving that conversation. So I think just reaching out to them and letting them know that these things are there and it will benefit their states, I think it's the way to go.
Okay, thank you so much, Dorcas. That will be all the questions from me to you. I don't see any other question from the question section. I have Bose De Akin Boluwasere. Forgive me, I hope I'm not just killing that name. Bose said it's been a wonderful conversation and also wanted us to note adolescents in humanitarian setting and their peculiarities. And he's saying we should note this when advocating and developing sexual reproductive health intervention targeting this group. I think that's just asking us to note this and in our intervention. So again, back to Oluyemisi. Oluyemisi is asking to understand, I think that was Carrie's presentation. Why was women spelled as WOMXN? Is there a specific reason, or is this a typo? Carrie?
Sorry, I'm just unmuting. No, it wasn't a typo. It's a term that's been used before to include all of the women that I spoke to earlier, trans, cis, non-binary. And after we had used it in the grant, there was some comments that perhaps using the X is not ideal. So in our grant, we've used the X in women. And we want to have a discussion with community members in the 7 countries about whether or not we'll continue to use that. But it is a term that's been used to encompass all women, non-binary, cis, trans, etc. Yeah.
Okay, thank you so much for that. Thanks, Dorcas, for that explanation. And I think there were 2 people that had the same comments on just understanding why women is spelled like that. And I hope they have their answers now. I just have this question, and it's open to any of the presenters to speak on it. The question is family planning in Nigeria a successful program in Indigenous community? And a writer to that is, how do you envision this linked with HIV program or campaign? Is there any speaker willing to talk on this? Or I can ask someone to speak on it. Oh, Walter is back. Thank you, Walter.
Oh yes. Just to write to before this one, I wanted to add a note of caution that Delta State is very successful because of the political will and commitment and understanding of what happened. I was the part of the team that came during the surge and launch and all of that, even HIV self-testing and all of that. The government is, accepting the program. But if you go to those states, you go to neighboring state, even Anambra State, I made so much effort to reaching the former governor and all of that. The story might really change. That's one. Number 2 caution is that HIV response for the surge had so much resources, donor funded. We now need to shift from donor funding to state-owned resources, and that is the way to go to sustainability. And that's the question you're asking. So can we say that family planning is largely successful? It's successful in 2 folds. One fold is that it's been successful driven by the private sector. If you go to chemists, which majority of the indigenous people use in the evening and TBS, they sell condoms there, so you readily see condoms to use as a family service. But in terms of STI services, apart from condom, you really majorly cannot see anything. The huge stigma also has made it not to actually succeed the way it should be. You walk into the local clinic or to the primary health center and you say, I would want you to give me or treat me for an STI, sexually transmitted infection. You are down with infection, and the information circulates around the community that this person has got a sexually transmitted infection. So in terms of the barriers, the misconception and myths that were surrounded with FP services has not actually allowed FP to thrive. It's also successful in the sense that at the global level, we have a commitment. Nigeria have joined the FP 2030 agenda, and we are fashioning out and aligning and adapting national and international guidelines for family planning services and aligning to those agreements. But these ones are being done in paper. But in the actual sense, at the community level, we are running HIV services on one bicycle side of the clinic or treatment center, and family planning services on the other side of it. In fact, we are even running them, delivering them with different implementing partners at the moment, apart from maybe OSS, which is trying to find a way to co-locate them. So in terms of the actual service, the practical ones in the communities, If I ask every of us in this evening to walk into your local center or local hospital and say, I would want to be provided with family planning services, you will see what will happen. Then the final point, which I think it's not successful, is that he has differentiated, or he has excluded the most vulnerable that should be on focus, and that is adolescent girls and young boys. He has differentiated and he has, excluded them from the main planning and implementation we should be having. They should be seated on the driver's seat, on the planning table, deciding how this should be done and how their health that matters to them should be in their hands. And this also includes, by extension, indigenous women, because they have been left out, and we have left the healthcare service providers to be the one determining what happens. And really, all countries of the world we have seen this is not the case, or this is not what it should be. Thank you.
Thank you so much, Walter. Thanks for taking a jab at that question. I think you did justice to it. From Femi Owolabi, Nigeria, he has said, excellent presentation by Dr. Dorcas. I must commend the works you and your team are doing in Delta State, especially the fact that your team have scaled up HTS services and treatment to the less privileged women and girls across the hard-to-reach area. So this is a shout out to Dr. Dorcas, and that's from Femi Owolabi. So we have just, how many minutes? Few more minutes, 4 more minutes to have discussion, questions and answers. And I want to give the floor to who has not gotten a chance to speak. Majula, do you have any addition to your presentation? Do you want to make additional comments?
Yeah, thanks so much. No, it's been great to listen to everyone. So many of these challenges, I think, as I mentioned in my presentation, have been there for decades. And I think unless we can collectively get together, and not just for the community engagement, but also to ensure, some of the other pieces that the presenters mentioned, such as, ensuring that there is budget for women-led organizations, that there's commitment at a political level, that, evidence-based information and tools are not only made available, but we ensure that the uptake of these tools, we're not going to be able to see the kind of progress that we'd like. So I really welcome these sort of initiatives and look forward to the next steps, and hope that, if we have this conversation again in the future, that we're able to show considerably more progress. Thank you.
Thank you so much, Majula. We actually have the last comments from the comment section, and that's in response to the answer provided by Carryover Women. And this is just saying that they will prefer that it's kept as women, because terms such as binary, gay, trans, etc. can always be explained on their own. That's the feedback from Oluyemisi. Just let's go over to the last section that we have for today, and it will be the closing remark. Closing remark will be given by Onyeka. Onyeka is a community leader. He's from Indigenous. He's an Igbo man, and he has been working on human rights, and he's an activist. Presently, the publicity secretary of Ikenga Nri Development Union. Please help me welcome Onyeka Christian as he gives the closing remark. Over to you, Onyeka. Onyeka, you're muted if you're talking. It appears we're having a challenge. We cannot hear Onyeka. He's tried to unmute himself, but we still can't hear him.
Can you hear me?
Yes, we can.
Okay, thank you. Thank you. Well, well, as we bring today's conference to a close, I want to say a big thank you to all those who contributed to the success of today's event. I thank you especially Ogochukwu Iwora for anchoring this program. Thank you so much. And I'm also immensely grateful to Chief Dr. Emma Nemua Ugodikenanri, who offered an opening prayer in a good way for this program. Adaman, to our resource persons, our presenters, I say a very big thank you for the in-depth and expository presentations you provided today. Carrie Martin from CAN, Majula from WHO, Dr. Dorcas from Caritas, and Dr. Walter from CISHAN. By highlighting indigenous issues as they concern sexual and reproductive health and rights of indigenous women living with HIV in Nigeria, you are contributing to the call for the recognition of indigenous peoples as a priority population in global response to HIV and AIDS. And indeed, there is need for greater involvement of indigenous people at the decision-making process of national and global response to HIV and AIDS, if we must address the proportionate impact of HIV and AIDS among indigenous peoples. I want also to thank my co-organizers who worked around the clock, Patricia Mahecha from CAN, and Ados May, the technical advisor at WHO, for all your efforts and commitment in organizing this webinar. Thank you so much. And members of the audience across the globe, I say thank you too. And I hope we will learn one or two things from today's webinar. I will also want to recognize indigenous women all over the world. Please, let's break the bias. Thank you so much. Thank you, everybody. Thank you.
Thank you so much, Onyeka. We appreciate that closing remark from you. Just to mention that before we close, there are links provided for you here. You can go to these links for additional information. We have the one for WHO guideline, and if you want to learn more about the work that CAN is doing and the work that WHO IP Network is doing, please use the link to visit their organization, to visit the website and learn more about it. So thank you, everyone. We appreciate. And from me to you all, it's goodbye. Thank you.
Thank you. Bye-bye.